In this section, we will be continuing our previous discussion. So, in the last session, we discussed about the clinical features and the laboratory investigations in respect to ARDS. In this section, we will be starting with the approach to the treatment and further sequelae of ARDS that we generally come across. So, approach to the treatment is divided into management of respiratory failure and uh, diagnosis and treatment of precipitating and other comorbidities. Before understanding the treatment of ARDS, we should first come to the goals of management of patients with ARDS. So, the treatment goals include the treatment of respiratory system abnormalities and the treatment of non respiratory system abnormalities. Now, in respiratory system abnormalities, the first thing is to diagnose and treat the precipitating cause if possible. Secondly, maintaining the oxygen level with a safer side of FiO2, that is a non-toxic FiO2 of less than zero point 0.7 PEEP or mechanical ventilation. Thirdly, prevention of ventilator-induced lung injury by using a low tidal volume strategy with a limit of less than 30 centimeters of water. Keep the pH in normal range without compromising goal to prevent the VILI, but reverse a life-threatening acidosis even if it prevents meeting the goal to prevent VILI. Enhance the patient ventilator synchrony by using various sedations and neuromuscular blockers. Liberate or wean from mechanical ventilation as soon as the patient can breathe without assisted ventilation. Thirdly, the treatment of non-respiratory system abnormalities. This includes support or treat other organ system dysfunction or failure, general critical care, that is preventive and homeostatic measures, and adequate early nutritional support. Now, I know that this particular statement might be confusing to you, that keeping the pH in normal range without compromising the goal to prevent the ventilator induced lung injury. Now, we all know that excess of oxygen, whenever you give, there is always a chance of ventilator induced lung injury. But at times, we need uh, in cases of life-threatening acidosis, there is a likely need to let the lung ventilate with a high tidal volume. So even if it may cause ventilator-induced lung injury, but if a life-threatening acidosis is present, then in that case, even if we need to increase the tidal volume greater than the safe side, then we should do it, and even at the cost of VILI if required, right? Then, after studying this, let's come to the diagnosis and treatment of precipitating causes and other comorbidities. Now, we don't want to dwell into each and every precipitating cause, but let's just divide the causes into the treatable causes into infectious etiologies and non infectious etiologies. So, the infectious etiologies that are treatable include diffuse bacterial pneumonias or sepsis, that is due to Legionella species, bacterial or other sepsis, that is due to Fungina, which is responsive to antimicrobials, diffuse viral pneumonias like cytomegalo, influenza A, and these days SARS-CoV-2, diffuse fungal pneumonias, that is Candida, Cryptococcus, or PJP, uh, other diffuse lung infections which include miliary TB. Then there are certain non-infectious treatable etiologies which we've come across. That is DH, could be due to bone marrow transplantation or ANCA-associated vasculitis, acute eosinophilic pneumonias, lupus pneumonitis, and toxic drug reactions, as in the case of aspirin. Then after this, coming to the next part, that is management of respiratory failure. Now, management of respiratory failure is a huge topic in itself. So, we have broadly divided into firstly, maintaining the adequate oxygenation, that is our goal number one. Secondly, lung protective mechanical ventilation. And thirdly, other approaches to ventilatory management. So, first, we'll talk about the maintaining or maintenance of the adequate oxygenation. Now, we know that ARDS in itself is a condition which requires high level of FiO2. But high level of FiO2 always is associated with various side effects. This includes the toxic effect of oxygen therapy in itself, right? And for this, you require PEEP. So when we know that high FiO2 can cause various injuries, as in the case of oxygen, as in due to oxygen therapy, PEEP is somewhere used which would reduce the need of the high FiO2. So PEEP is employed to improve oxygenation by reducing the physiological shunt. The FiO2 eventually is allowed to be lowered from high potentially toxic concentrations. So how does PEEP function? PEEP functions by number one, recruitment of the collapsed alveoli, number two, redistribution of the alveolar fluid, and number three, decrease the absolute magnitude of shunt. So these are the three functions of PEEP. Then to deliver adequate oxygenation, we at times also use non-invasive ventilation. Now, the reason non-invasive ventilation is not used because we do not have still a lot of results for it. But in certain patients, certain selected subgroups, like in cases of immunosuppressed patients with hypercapnic respiratory failure, which are hemodynamically stable, in these patients we can use NIV. Then coming to the lung protective mechanical ventilation, right? Now remember that the goal of mechanical ventilation is to prevent the lung protective mechanical ventilation is to prevent volutrauma, atelectotrauma, and biotrauma. Volutrauma, like the word suggests, avoiding injury due to overexpansion of the alveoli during inspiration. Atelectotrauma is injury due to repetitive opening and closing of the alveoli during inspiration and expiration. And biotrauma is when you have direct lung injury, and due to this, there is a release of various inflammatory cytokines which may involve even the distant organs, leading to multi organ involvement. So, these are the goals of lung protective mechanical ventilation. Now, why is it important? Is because the key physiological implication, like this book states, that these observations is that ventilator derived tidal volume is preferentially distributed to the open alveoli, which represent only a small fraction of the entire lung. Now we know that in an ARDS lung, only a percentage of alveoli are functioning normally. So whenever you're giving a tidal volume, a high tidal volume, the tidal volume needs to be distributed equally in the existing alveoli. So if you're giving a tidal volume of say 800 mils, and if you have say 10 alveoli, then it has to be distributed amongst these 10 alveoli. But is it healthy to distribute 800 ml of tidal volume amongst 10 alveoli? No. You require higher alveoli. And how do you do that? By recruitment. And how does it happen? By giving positive and expiratory pressure. Now, why we are talking about all this? Due to due to acute lung injury. So acute lung injury happens when you give large tidal volume ventilation, when there is repeated opening and closing of alveoli, and when there is overexpansion of the alveoli in normal lungs, right, which induces further multi-organ failure. So based on all this, the ARDS net strategy was devised. So according to this, in the part 1, first of all, about the ventilator setup and adjustment. So you first calculate the idle body weight, use the assist control mode and set the initial tidal volume to 8, right? If the baseline is more than 8. If the baseline is more than 8, you should reduce it by 1 ml per kg at intervals of less than or equal to 2 hours until you reach a tidal volume of 6 mils per kg idle body weight. You should set the initial rate to approximate the baseline minute ventilation, but the rate should not be more than 35 beats per minute. Adjust the tidal volume and respiratory rate to achieve the pH and the plateau pressure, right? The goals are given below. Set the inspiratory flow rate above the patient demand, usually more than 80 liters. Adjust the flow rate to achieve the goal of IE ratio 1 is to 1 or 1 is to 1.3. The second is oxygenation. The goal of oxygenation is a PO2 of between 55 and 80 millimeters and a saturation between 88 and 95. So this is the table which we can refer to using these incremental FiO2 PEEP combinations to achieve the oxygenation goals. Part 3 is how to use the plateau pressure. The plateau pressure goal should be less than or equal to 30 centimeters of water. So you should check the plateau pressure using 0.5 second inspiratory pause, saturation, total respiratory rate, tidal volume, and ABG if available. All these are supposed to be assessed at least every 4 hours and after each change in PEEP or tidal volume. If your plateau pressure is going above 30 centimeters, you need to decrease the tidal volume. How do you do it? By decreasing it by 1 mil per kg steps, the minimum you can go down to is 4 mils per kg idle body weight. If your plateau pressure is going to less than 25 centimeters and the tidal volume is less than 6 mils per kg, you increase the tidal volume by 1 mil per kg until your plateau pressure climbs up to more than 25 centimeters, or the tidal volume is 6 mils per kg. But then, if the plateau pressure is going even below 20 centimeters and breath stacking occurs, one may increase the tidal volume in 1 mil per kg increment to a maximum of even 8 mils per kg. And part 4 is pH. The goal of the pH should be between 7.3 and 7.45. Acidosis management is done when the pH is less than 7.30. So if the pH is between 7.15 and 7.30, you need to increase the respiratory rate until the pH is more than 7.3 or a PaO2 of less than 25 millimeters with the maximum RR of 35. If the RR of 35 and the PaCO2 of less than 25, you may give bicarbonate. If the pH is less than 7.15 and bicarb is considered or infused, the tidal volume may be increased in 1 mil per kg steps until the pH of more than 7.15 is achieved. In cases of alkalosis management, for a pH of more than 7.45, you need to decrease the respiratory rate if possible. Right? So, this is the central strategy that we should always keep in mind. Right? So, word about use of high PEEP. So does a high PEEP can protect your lung? Well, see, we had a LOVES trial and we had the EXPRESS trial. Uh, Although there was not a significant improvement with high PEEP, there was no difference in mortality, but high PEEP strategy improved secondary endpoints, including use of rescue therapies and duration of mechanical ventilation and organ failure. Right? Um, but using a high PEEP caused a reduction in mortality in patients with a PF ratio of less than 200, right? So this was an interesting finding. So the recommended core ventilator management is you follow the ARDS net protocol and modifications should be considered only in special cases. Remember that. Modifications, by means of modification, what I mean is using at times, for example, permissive hypercapnia, right? Sorry for the dogs. Then coming to the modes of ventilation, the management of respiratory failure per se, right? So we saw that, right? Then we saw the lung protective we saw the lung protective strategy, right? Then coming to other approaches of ventilatory management. So in this, first we'll talk about the modes of ventilation. We specifically use pressure control mode of ventilation, right? So pressure control ventilation, it basically limits the maximal peak airway pressure as well as end inspiratory pressures. Now the end inspiratory pressure in PCV can be underestimated. For example, using the pressure control ventilation with an inspiratory pressure of 30 centimeters and a PEEP of 10, the end inspiratory pressure is 40. Now, some may misinterpret this combination as equivalent to a plateau pressure of 30 and assume that it is safe value according to interpretation of ARDS net results, but it is actually 40, which is higher than the plateau pressure that our goal actually tells us to. So in that case, we need to reduce the tidal volumes, right? So that is something that has to be kept in mind. Secondly, the use of pressure control ventilation to mimic both tidal volume and the plateau pressure used in ARDS net trial, that remains problematic. Why? Because the tidal volume delivered at a set pressure in the pressure control ventilation is dependent on the compliance of the respiratory system and is therefore variable, particularly in ARDS, because the compliance varies a lot. So even if you're giving a constant pressure, you do not know whether the tidal volume being delivered is adequate or not because the compliance is actually changing every time. Then it may be difficult to in the pressure control ventilation to ensure tidal volumes, like I said, particularly as compliance improves as ARDS improves. Because when compliance would improve, naturally there will be more tidal volume would be generated, right? So as at the same set of pressures, a larger tidal volume might be generated because of better compliance, right? And then with pressure control board, at times we also use inverse ratio ventilation with PCV. That is, the inspiratory duration of inspiration is increased, right? So inverse ratio ventilation also limits the time for exhalation, right? So obviously, if you increase the time for inspiration, exhalation time would obviously be limited. And this potentially results in dynamic hyperinflation and autopeep. So you're not giving the time for the air to move out of the lungs. So that is eventually going to cause hyperinflation and autopeep, right? So inverse ratio ventilation with autopeep plus the applied peep, all this may compromise the cardiac output and increase the risk of non-pulmonary organ dysfunction, because with such a positive pressure, the intrathoracic venous return would get affected, and this would eventually lead to less cardiac output or compromised cardiac output, right? Then, after considering the pressure control mode, let's come to spontaneous breathing during positive pressure ventilation, right? Now, we know now spontaneous breathing during positive pressure ventilation can also be kind of used can also be used as a mode of ventilation. In this, the airway pressure cycles between higher and lower levels of PEEP at preset time intervals, that is the IPAP and EPAP that we set in devices. Broadly, these are divided into two. We have the biphasic airway pressure or BiPAP, and then we have the airway pressure release ventilation or APRV, right? So, uh, the advantage of spontaneous breathing during PPV is that it decreases the use of neuromuscular blocking agents and possibly sedation, right? So, but again, the routine use of this is not recommended. Word about APRV or airway pressure release ventilation. So, this represents basically an extreme of BiPAP, whereby patients are given a high level of PEEP to promote alveolar recruitment with a brief release to allow for carbon dioxide removal without allowing alveolar de-recruitment, right? Then, secondly, the decreased intrathoracic pressure, improved VQ mismatch and cardiac output, and decreased shunt and dead space fractions compared with pressure support ventilation are seen with this. And but again, like clinically important outcomes were not compared, right? Then coming to the high frequency oscillatory ventilation or HFOV. Now, in this, there is a rapid pressure oscillation that generates very small tidal volumes. This type of ventilation is commonly used in respiratory distress of the newborns. The trial conducted by the Oscillation ARDS, that is the Oscar trial and the Oscillate trial, both of them were not able to give a favorable response to HFOV. HFOV may, in the cases of Oscar, there was no significant mortality benefit, and in the Oscillate trial, they actually had to stop the trial because of increased mortality using this particular mode of ventilation, right? After this, let's come to the other approach includes adjuncts to then these were all about lung protective mechanical ventilation and other modes. Then there are certain adjuncts to it, which includes first of all permissive hypercapnia. Now, what is permissive hypercapnia? This is nothing but a clinician allowed hypercapnia during assisted ventilation despite an ability to achieve a level of minute ventilation sufficient to maintain a normal PCO2, right? So there are certain contraindications. This includes increased intracranial pressures from any cause, as in the case of trauma, mass lesion, or malignant hypertension, acute cerebrovascular disorders, for example, stroke, acute or chronic myocardial ischemia, severe pulmonary hypertension, right ventricular failure, uncorrected metabolic acidosis, sickle cell anemia, tricyclic antidepressant overdose, patients taking beta blockers, pregnancy due to the potential for decreased fetal blood flow from vasodilation induced Steele syndrome, right? Then, apart from that, the second is fluid management. Now, the fluid management was basically governed by the FACT trial, that is a fluid and catheter treatment trial. So, this basically recommended the use of conservative fluid strategy in managing patients with ARDS who are not in shock. So, this particular judgment was based on four basic input variables which were assessed every 1 to 4 hours. Number one, the mean arterial pressure. Number two, the urine output. Number three, effectiveness of circulation. And number four, intravascular pressure. That is using either CVP or pulmonary artery occlusive pressures. The goals were a mean arterial pressure greater than 60 millimeters of mercury or a vasopressor independence, a urine output greater than zero point 0.5 mils per kg body weight per hour, and evidence for effective circulation, including a cardiac index of more than 2.5 liters per minute per square in patients with PACs or in those with CVCs. Absence and finally, and also absence of physical exam findings indicating hyperperfusion of the extremity. So, all these are protocol goals. So, in the fact trial, there was no statistically significant difference in mortality seen, when you compared the patients who were given liberal fluid management as compared to the ones who were given a conservative fluid management. But yes, conservative strategy resulted in statistically significant improvement in clinically important outcomes, which included a decrease in the duration of assisted ventilation and length of stay in the ICU. Right. Then coming to the hemodynamic management. Now, PAC or pulmonary artery catheters were compared to the central venous catheters. So, pulmonary artery catheters had a significantly higher complication rate during catheter insertion, primarily cardiac arrhythmias. So, fact investigators recommend using a central venous catheter to guide a hemodynamic and fluid management. But yes, you at times you need to use the pulmonary artery catheters, especially in addressing the response to volume resuscitation, determining the adequacy of cardiac output, measuring oxygen saturations of mixed venous blood, calculating the degree of intrapulmonary shunt, or searching for equalization of diastolic pressures during suspected cardiac tamponade. Then we come to recruitment maneuvers. Now, recruitment maneuver is nothing but application of CPAP aimed at recruiting or opening totally or partially collapsed alveoli. The alveoli are then kept inflated during inspiration using an appropriately high level of PEEP. This can cause transient hypotension and slight drops in arterial saturation. Therefore, this routine use is not recommended. Then we come to prone positioning. Now, the advantage of prone positioning is that it increases the FRC. There is a change in the regional diaphragmatic motion. Perfusion redistribution is encouraged, and there is improvement of the clearance of secretions. Right. Another thing which prone positioning gave us was that gravity is less influential on the distribution of perfusion in the prone position rather than in the supine position. But keep in mind that you have to prevent pressure necrosis of the nose, ears, and ears, ensure security and patency of the ET tube. Pressure on the eye may result in retinal ischemia, especially in hypotensive patients, cardiac arrhythmias, or hemodynamic instability. Then we come to inhaled nitric oxide. Now, inhaled nitric oxide के केस में selectively it basically vasodilates pulmonary capillaries and arterioles that serve the ventilated alveoli, diverting the blood flow to these alveoli and away from areas of shunt. So, theoretically, it can help. But then, the disadvantage is that you need to send continuous delivery of this gas through the circuit, even if for some time if it is interrupted, like during patient transport or due to supply exhaustion. Precipitous and life-threatening hypoxemias and right-sided heart failures may occur. So therefore, the routine use of inhaled nitric oxide is also not recommended. Then tracheal gas insufflation. The concept behind is that you deliver fresh gas through a modified ET tube at a point just above the carina. So the idea behind this is that it tends to remove the carbon dioxide rich gas from the trachea and smaller airways. But there is a potential risk, for example, tracheal erosion, oxygen toxicity related to an increase in FiO2, and hemodynamic compromise or barotrauma due to the tracheal gas insufflation or TGI induced auto PEEP and a larger tidal volume than the ventilator is set to deliver. So therefore, its routine use is not recommended, tracheal gas insufflation. Then we come to extracorporeal life support. Now, extracorporeal life support is nothing but external artificial membrane and a mechanical pump to provide gas exchange and systemic perfusion in patients with failure of lung or heart function. There is a potential role in reducing the VLI using the ECMO, and basically the lung is allowed to recover from its injury by resting, right? And this is what was the CESAR trial basically, you know, demonstrated its efficacy. Then coming to corticosteroids. Now, steroids may be beneficial during proliferative phase based on rationale of preventing lung scarring, right? And the parameters of respiratory function, including the PF ratios, the plateau pressure, the respiratory system compliance, and time and rate of liberation from mechanical ventilation, they improved after corticosteroids according to some studies. But the problem is that the patients who were treated with steroids even after 14 days of persistent ARDS, they had a significantly increased mortality. Now, this could be attributed to either immunosuppression, neuromuscular weakness, or uh, uh, or neuromuscular weakness, and all this actually led to increased return to the assisted ventilation. Then coming to neuromuscular blocking agents. Now, neuromuscular blocking agents promote ventilator synchrony and improve the oxygenation in severe cases of ARDS, but it's only useful for short term use in severe ARDS. Other therapies include rosuvastatin, which has its effect on the inflammatory cytokines, and beta agonists, which theoretically stimulate the removal of fluid, but it has failed to demonstrate a mortality benefit, due to various trials. Now, after studying all this, let's come to the final section, that is the clinical course outcome and long term sequelae. So, clinical course and duration. The median duration, like we discussed in the initial hours of this, the median duration of mechanical ventilation, according to mild, moderate, severe, is 5, 7, and 9 days. Up to 25% of the patients remain on mechanical ventilation for longer than approximately 2 weeks. Most of the deaths occur within the first 2 weeks, with one third occurring by day 7, two-thirds by day 14, and three-fourths and four-fifths by day 28. Coming to the causes of death. Now, causes of death could be either due to the underlying disease which has caused ARDS or the complications of whatever you have done for the patient, right? Complications include sepsis or patients who are in sepsis or with MODS. Only 10 to 20% of all the patients with ARDS, they actually die a respiratory death due to irreversible hypoxemia or refractory respiratory acidosis. Most of the times it happens due to sepsis and MODS. Remember that, and eventually which leads to MODS. Coming to the long term sequelae. Now, it is important for us to recognize the problems which affect the survivors of ARDS, and we should refer these patients for appropriate services. That should form an important constituent of our daily practice. So, how do you measure the sequelae? By using the health related quality of life, or HRQL. The impairment in HRQL improves over the first 3 months following discharge from ICU and appear to plateau by 1 year. Coming to pulmonary sequelae, this may have impaired diffusion capacity or restrictive or obstructive abnormalities. Um, uh, Restoration of the normal lung function occurs in a substantial proportion, so that is good. Diffusion capacity also is very mildly impaired. Coming to physical and neuromuscular sequelae. So, there is a low exercise capacity, weakness, and decreased physical activity. Risk factors include multi organ dysfunction, prolonged duration of ARDS, and treatment with steroids. This can lead to critical illness polyneuropathy, ICU acquired myopathy, entrapment neuropathy, and heterotopic ossification. Coming to the cognitive and psychological sequelae. Now, this appears to be worse in the first 3 months following hospital discharge, but this may improve for up to 1 year and then reach a plateau. Prior hypoxic brain injury and delirium and subsequent limitation of physical functions may be an underlying cause in these conditions. Of course, PTSD is one of the most important causes whenever you find a traumatic cause for ARDS. Um, Following up the patients for ARDS should aim to ensure adequate social and other support, not just for the patients but also for the caregivers, because they also face a lot of trouble due to this, due to a patient, post discharge rehab, etc. So, all these conditions need to be addressed. So, with this, we end this chapter and hope it was enlightening enough. And we will continue our discussion in the subsequent sections. Thank you.